Welcome to Emergency Insights. I'm James Carter. Today, we're discussing a critical topic in trauma care, the pre-hospital administration of tranexamic acid, or TXA. We have an expert with us to break down the latest recommendations. Please welcome Dr. Peter Wang, a leading voice in emergency medicine. Dr. Wang, thank you for being here.
Thanks, James. It's a pleasure to be here.
Dr. Wang, let's start with the big picture. Why is there a growing focus on using TXA in the pre-hospital setting for trauma patients?
That's an excellent question. The primary reason is to improve patient outcomes, particularly for those with hemorrhagic shock. Major trauma with significant bleeding is a leading cause of preventable death. TXA is an antifibrinolytic agent. What it does is stabilize blood clots, preventing them from breaking down too quickly. By giving TXA early on, even before the patient reaches the hospital, we can potentially mitigate life-threatening hemorrhage and improve survival. The evidence from major studies like the CRASH-2 trial has shown a significant mortality benefit when TXA is administered within 3 hours of injury.
And what about safety? Are there any significant risks that pre-hospital providers should be aware of when administering TXA?
The guidelines are quite clear on this. Pre-hospital TXA administration appears to be remarkably safe. The risk of serious adverse events like thromboembolic events or seizures is very low, especially at the doses being studied. The key is to use it on the right patient at the right time. For patients with hemorrhagic shock, the benefit of potentially saving a life far outweighs these minimal risks.
The guidelines mention that the ideal dose hasn't been definitively determined. What are the current recommendations for dosing and administration?
Right now, there are a couple of recommended approaches. EMS agencies can administer a 1-gram intravenous or intraosseous dose as an infusion or slow push in the field. This should ideally be followed by a hospital-based infusion of another 1 gram over 8 hours. The other option, which some agencies are adopting, is a single 2-gram dose given as an infusion or slow push in the pre-hospital setting. The benefit of the single 2-gram dose is its simplicity in the field, reducing the risk of a missed second dose later. Both approaches have been shown to be effective.
Timing seems to be a crucial factor here. The guidelines specify a window for administration. Could you elaborate on that?
Absolutely. The evidence is very strong that TXA's benefit is time-sensitive. It should be administered to patients with clinical signs of hemorrhagic shock no later than 3 hours post-injury. There's no current evidence to support its use beyond this 3-hour window. In fact, some studies suggest that giving it after this period might actually be harmful. It's also critical that it's given only to patients with clinically significant bleeding. Using it on patients without signs of major hemorrhage has not been shown to be beneficial.
The guidelines also touch on pediatric patients. What are the current recommendations for using TXA in this group?
The short answer is that the data is still very limited. The role of pre-hospital TXA in pediatric trauma has not been well studied, and standardized dosing hasn't been established. The current recommendation is that if it is used, it should also be within the 3-hour window. However, this is a topic that definitely requires more research before it becomes a standard practice.
Communication is vital in emergency care. How should pre-hospital providers ensure a smooth handover regarding TXA administration?
Clear and concise communication is absolutely essential. When handing over the patient to the traumas team, the EMS provider must clearly state that TXA was administered, including the dose and the time of administration. This prevents a duplicate dose from being given in the emergency department, promotes appropriate monitoring for the patient, and ensures the patient is part of a standardized care pathway.
Finally, the recommendations emphasize the need for a quality improvement program. What does this involve?
This is a crucial point for implementation. A multidisciplinary team led by EMS physicians, including EMS clinicians, emergency physicians, and trauma surgeons, should be responsible for developing a quality improvement program. This program should be used to assess protocol compliance, identify any clinical complications, and review patient outcomes. It's about ensuring that we're not just following a new guideline, but that we're doing so safely and effectively, and that it is truly making a difference in our patients' lives.
Dr. Wang, this has been incredibly insightful. Thank you for your time and for shedding light on these important guidelines.
My pleasure, James. Thank you for having me.
That's all the time we have for today. Thank you for tuning in to Emergency Insights. We'll be back next time with another deep dive into the world of emergency medicine.